Medically speaking, an upper gastrointestinal hemorrhage has a strict anatomical definition. It refers exclusively to bleeding that arises proximal to the ligament of Treitz, the suspensory muscle anchoring the junction of the duodenum and jejunum. This clinical decision tree maps out the mandatory first step in assessing any patient with upper GI bleeding. Presentations must be immediately bifurcated into two categories: non-variceal bleeding, accounting for roughly 80% of cases, and variceal bleeding, making up the remaining 20%. As the diagram expands downward, the underlying etiology, pathophysiology, and resulting management strategies share almost no overlap. For both pathways, upper GI endoscopy serves as the absolute clinical cornerstone. It is the single most important investigation because it allows the clinician to secure a definitive diagnosis and immediately execute a therapeutic intervention in the same procedure. Recognizing this anatomical boundary and correctly assigning the patient to the variceal or non-variceal pathway dictates every subsequent medical decision. It is the prerequisite for arresting decompensation. When deploying an endoscope, spatial orientation is tracked meticulously. The universal standard for measuring insertion distance begins at the patient's upper incisors. Navigating downward, the first critical landmark is the gastroesophageal junction. The clinician identifies this boundary visually by noting the distinct transition from pale esophageal tissue to the red columnar mucosa of the stomach. Pushing through the stomach and past the pyloric sphincter, the endoscope enters the duodenum. This region is distinguished from the gastric environment by the sudden appearance of prominent circular folds. To inspect the highest portion of the stomach, the fundus, the clinician must perform a mechanical retroflexion. By curling the scope into a tight J shape or U shape, the camera looks back upward at the gastric ceiling. Absolute spatial awareness and the rapid recognition of these normal topographic landmarks allow the endoscopist to accurately pinpoint bleeding sources. Peptic ulcer disease is the single most common cause of upper GI hemorrhage, with duodenal ulcers appearing more frequently than gastric ulcers. Looking at this anatomical wireframe map, we can isolate the highest risk lesions. Posterior duodenal ulcers are the most likely to bleed because they erode directly into the gastroduodenal artery, positioned immediately behind the duodenal wall. Moving to the stomach's lesser curvature, we find the left gastric artery. This is the classical vascular source implicated when a gastric ulcer hemorrhages. The management principle for peptic ulcer bleeding is strict. A maximum of 2 endoscopic therapeutic attempts may be made to secure hemostasis. If bleeding persists, the protocol escalates to surgical intervention. Gastritis presents a different topographic pattern depending on its origin. Type A, or autoimmune gastritis, generates antibodies against parietal cells. It typically involves much of the stomach body while completely sparing the antrum. Type B is bacterial, driven by Helicobacter pylori, and concentrates its inflammation heavily in that same antral region. The stomach mucosa is uniquely vulnerable to hypovolemia. A severe drop in blood volume rapidly induces ischemic injury, resulting in stress gastritis. Severe systemic trauma generates specific named stress ulcers. Cushing ulcers correlate with head injuries and form in the acid-producing regions of the stomach. Curling ulcers follow severe burns and localize primarily in the first part of the duodenum. Resolving non-variceal hemorrhage requires localizing a specific mucosal defect and matching it precisely with a targeted mechanical clip, injection, or thermal countermeasure. Traumatic esophageal injuries demand careful distinction. A Mallory-Weiss tear is a longitudinal mucosal tear near the gastroesophageal junction, typically caused by forceful retching. Boerhaave syndrome is a full-thickness transmural perforation of the esophagus, requiring immediate surgical repair. This side-by-side schematic illustrates 2 distinct vascular anomalies. On the left is gastric antral vascular ectasia, or GAVE. It features dilated venules that create linear red striations in the antrum, often called a watermelon stomach. It is typically treated with argon plasma coagulation. Contrast GAVE with the image on the right, portal hypertensive gastropathy. This condition involves the wider gastric body and presents with a diffuse, mosaic snakeskin appearance, requiring portal pressure management rather than local coagulation. A Dieulafoy lesion occurs when an abnormally dilated submucosal arteriole erodes through the gastric lining. It causes massive, entirely painless hemorrhage, frequently in elderly males, and requires immediate endoscopic coagulation. Menetrier disease is a hypertrophic gastropathy driven by the overexpression of transforming growth factor alpha. Endoscopy reveals giant gastric folds. Patients present with protein-losing enteropathy, severe weight loss, upper GI bleeding, and an elevated risk of gastric carcinoma.
Initial medical therapy targets the EGFR pathway with cetuximab. If pharmacological management fails or if malignancy is suspected, total gastrectomy is the necessary salvage protocol. Survival in these atypical non-variceal bleeds relies on clinician pattern recognition, identifying specific visual markers to accurately distinguish a localized hypervascular lesion from malignant proliferation. Shifting to the variceal pathway, the underlying mechanics change entirely. Variceal hemorrhage is the direct result of portal hypertension, which forces blood into portosystemic collateral veins until their fragile walls rupture. This dynamic chart visualizes the hepatic venous pressure gradient. A normal gradient sits below 5 millimeters of mercury. Hit 10 and the pressure threshold is crossed. Varices begin to form. Cross 12 and the risk of catastrophic variceal rupture becomes imminent. Portal hypertension is categorized anatomically by mapping the site of the vascular blockage. The origin can be prehepatic, intrahepatic, or posthepatic. A classic prehepatic cause is splenic vein thrombosis, frequently triggered by pancreatitis. This isolates the pressure buildup, causing left-sided or sinistral portal hypertension. The definitive cure is a splenectomy. Budd-Chiari syndrome represents a posthepatic obstruction. The hepatic venous outflow is blocked, leading to severe liver congestion. It correlates heavily with prothrombotic states, like protein C or S deficiencies. In Budd-Chiari, segment 1 of the liver, the caudate lobe, often undergoes severe hypertrophy. Because its venous architecture drains directly into the inferior vena cava, it is spared from the hepatic vein obstruction and compensates by enlarging. Unlike a discrete peptic ulcer, a bleeding varix is a symptom of systemic hemodynamic failure. Arresting the hemorrhage demands wide-scale vascular pressure manipulation to address the underlying portal tension. When varices ruptures, the initial resuscitation strategy relies on permissive hypotension. Clinicians target the lower limit of a normal systolic blood pressure. Rapidly pumping in massive volumes of IV fluid increases portal pressure and dislodges newly formed clots, worsening the hemorrhage. Pharmacological management follows strict protocols. Intravenous terlipressin is the preferred splanchnic vasoconstrictor. IV propranolol must never be used in the acute setting, and IV proton pump inhibitors are deliberately delayed until after endoscopic confirmation. Endoscopically, band ligation is heavily preferred. It secures mechanical control by strangulating the varix. The alternative, chemical sclerotherapy, relies on injecting fibrotic agents, but carries severe risks of esophageal wall necrosis and perforation. If endoscopy is delayed, balloon tamponade acts as a physical bridge therapy. The Sangs-Dakin-Blackmore tube utilizes inflated balloons to compress the bleeding vessels. However, the esophageal balloon must be deflated every 12 hours, or the constant pressure will cause esophageal necrosis. This diagram outlines the transjugular intrahepatic portosystemic shunt, or TIPS. It is the salvage procedure deployed when two separate endoscopic attempts fail to control the variceal bleeding. TIPS forces a brutal physiological trade-off. By connecting the portal vein directly to the hepatic vein, it successfully decompresses the system. But because it is a non-selective shunt, it diverts gut-derived toxins directly into the systemic circulation, severely predisposing the patient to hepatic encephalopathy. Managing variceal bleeding is a rigidly sequential escalation. The clinician must accept increasingly dangerous systemic side effects to prevent immediate exsanguination. Quantifying the risk in any GI hemorrhage requires the application of validated prognostic scoring systems. Criteria like BLEED, ROCKALL, Glasgow-Blatchford, and AIMS-65 predict rebleeding and mortality, while the Child-Pugh score grades the severity of underlying liver dysfunction. This data matrix outlines the FOREST classification, an endoscopic scoring tool predicting ulcer rebleeding risk. Stages 1A and 1B capture active spurting or oozing blood, indicating high risk. At the other end, Stage 3 represents a clean ulcer base, dropping rebleeding risk significantly. Using these frameworks, clinical deduction becomes rapid and accurate. A patient presenting with a history of heavy alcohol intake, forceful retching, and hematemesis maps directly to a Mallory-Weiss tear.
An elderly male patient experiencing massive, painless upper GI bleeding with an initially normal endoscopy points straight to a hidden doulofoy lesion. A young woman with chronic pernicious anemia and inflammation throughout the body of the stomach with a spared antrum confirms type A autoimmune gastritis. Mastering the upper GI hemorrhage algorithm moves the clinician beyond reacting to blood loss. It provides the framework to anticipate physiological cascades and tailor complex interventions, prioritizing the patient's systemic stability over the isolated pathology.